actually, I wanted to say, yeah, this is so enzymatic fat necrosis. All right, so the difference between enzymatic fat necrosis versus, the traumatic fat necrosis is what? The end result is going to be almost actually coming down with the same kind of final results in terms of, loss of pancreatic tissue, loss of peripancreatic fat, right? Necrotic, area all around. But the difference between the two is that the enzymatic fat necrosis is happening as a result of the enzymes of the pancreas itself getting activated within the body of the pancreas, as opposed, on the rush border of the pancreatic matter in the duodenum. Whereas, with the traumatic fat necrosis, it is simply like, any part of the body that get traumatized or that get injured, where you will see that actually it's going to be an inflammatory cells that will be rushed into the side that will take care of business, right? That are going to be actually, liquefying that region, creating necrosis, and then clearing it up, with macrophages, and then simply building, fibrous tissue in that side. Now here, what you can see some differences in terms of gross morphology and also, X-ray findings and also microscopic, findings. For example, here you will see that the calcium is really, is represented heavily with the enzymatic fat necrosis, with the acute pancreatitis resulting from the activation of the enzymes itself. That is not to say that you may not see it. It is not really, specific, but it is highly characteristic that you will see with the enzymatic fat necrosis and not the traumatic fat necrosis. On the other hand, you will see that as a result of the mechanism that we talked about, right? So the mechanism that we talked about, which is that the enzymes of the pancreas, especially the lipases, will break down the triglycerids into fatty acids. Fatty acids are going to combine with the calcium that are going to result in this calcium soup, if you will, calcium salts in the upper epigastrum that are going to show up also on the gross morphology when you take out, the pancreas, when you dissect the back pancreas in the form of chalky white calcium deposits. Now, as I mentioned to you, one actually of the criteria for how severe acute pancreatitis is how much that kind of deposits are present in the upper abdomen. The heavier the deposits, the lower the calcium level, the more acute, the more severe the acute pancreatitis will be. Right, and what do you see here? When the calcium actually is going to be mixed up with the fat, and then you stain it with hematoxin and eosin, the cytoplasm of the fat cells will take a basophilic, staining appearance. So it will look bluish, and that's exactly what you find here. Again, depending on if you can see actually, how they call it, red colors, right? A lot of pathologists cannot really differentiate, especially men. Men are very challenged in many different ways. One of them is colors, really. What color are you looking at? This is not a joke. There's something called color blindness. Have you guys heard about it?
Yes.
A lot of pathologists are really, have this problem, and that may create an issue, especially in diagnosis. So one of the things they do before they go into residency, they make sure that the pathology resident or the pathology candidate is not colorblind. One way to figure out that you're fit for the great specialty of pathology. All right. So what is this here? These are the calcium deposits that we talked about. Okay. So where did it came from? It came from the fact that actually the enzymes of the pancreas itself broke down the fat, and then that fat combined with the calcium in the blood, resulting in this, in this appearance right here, in this, subqualification process that is mentioned here. Okay. Now, as I mentioned to you, whether it is traumatic or enzymatic, both of them actually are liquefactive kind of necrosis. Why liquefactive? Because when you look at the pancreas, you will see that, so it's simply not just, the fat tissue that is dead, but the pancreas tissue is dead as well. It will actually be what you call ground zero for the killing field, right? Because that's where the enzymes are, set free to start with, correct? In the pancreatic tissue itself, and you can see here that you no longer see any outline for those cells, which is liquefactive by definition. You have a question?
Yes, doctor, I don't understand. Can you just repeat?
Right. So what happened actually? So let's say someone is alcoholic, okay, or someone is is having the problem actually emptying, his pancreatic duct for whatever reason. That could be a stone in the pancreatic duct. That could be actually a stone in the ampulla of Vater itself that creates a spasm in the ampulla of Vater, and as a result of that, the pancreatic duct will not empty freely. Okay. The end result is going to be what? The end result is going to be activation of the pancreatic enzymes in the pancreatic cell itself, okay? So those enzymes are going to be then let out. So they are going to eat up the pancreatic tissue itself, as you can see here. Then they will start to wreak havoc on the peripancreatic fat tissue, okay? And that's exactly what happened. So it will go into the fat tissue and will start to break down this fat tissue into fatty acids. The fatty acids that are going to be, set free here, they are going to combine with the calcium coming through the blood that will show up in this fatty acids. So the more calcium you have, that means actually the more necrosis you have, which is an indication of the severity of the acute pancreatitis. Which means you're going to be seeing, when you do the X-ray of the patient, you're going to be seeing tons of this calcification. Of course, it's not really like, it's a very kind of subjective kind of finding, but the heavier calcification, that's, the more acute the pancreatitis. Yes?
So at the beginning, when the enzymes start to attack the pancreas tissue, this is liquefactory, necrosis.
All of it is liquefactive. Even this one is liquefactive as well.
But this will start as fat necrosis, then it will become...
Well, fat necrosis, but what is fat necrosis in this case? If you look at this cell, this is normal. Again, in pathology, you compare it with the normal. This is normal fat. How do you know it's normal fat? You look at the nucleus. If the nucleus is there, the cell is alive, okay? So this is normal fat tissue, okay? Now you actually look at this, where are the nuclei here? They are gone. So simply, what kept actually this like this is the fact that calcium has becoming deposited on it, okay? So I would actually take that, and I would agree probably with you that it may actually show up in the form of coagulative necrosis. Yes, I agree with that. Why? Because you can still see the silhouette of these cells. You're absolutely right. Okay. So as long as the silhouette, the outside appearance of the cell is still there, then that probably actually is a differentiating point between enzymatic fat necrosis and traumatic fat necrosis. Because in this case, let's say that someone got also on the upper abdomen, a hit on the upper abdomen, right? In this case, you will see, or a hit on the, for example, on a fatty area, for example, the breast, or for example, the back. What's going to happen, the inflammatory cells that will be brought to the site are going to liquefy everything, right? Nothing will stay there, actually. So the end result will be that no cell outlines will stay, which is a differentiating point between, traumatic versus enzymatic fat necrosis. Good job. Okay. All right. So again, this is I think that back what I told you. As long as you're seeing actually the outside, the outline of the cell, that actually makes it into a coagulative necrosis. It is not a liquefactive. Liquefactive, nothing stays, right? Everything is gone. Here you still have, the outside, of that cell that is going to, make it actually into a form of coagulative necrosis. All right, now traumatic fat necrosis, as I mentioned to you, secondary to trauma. And injury, whether it is trauma, ischemia, whatever it is, the end result is going to be what? Bringing in, the defenders, right? That's in the form of white cells. Those are going to be the MAX and the neutrophils that are going to let out of those, highly degraded enzymes that they carry that are going to take care of business in a wholesale. They are going to take care, they're going to destroy and liquefy everything in that process, meaning nothing will stay. There is nothing that's going to stay, no outline of cells. So that's definitely what you're going to be calling actually liquefactive necrosis. Now, one thing that may happen actually is that, once, the tissue is gone, once the liquefactive necrosis, sets in, and then, you have the macrophages coming in and gulping up this cell debris, then fibroblasts will be brought in, right? Will be invited into the site of injury. Fibroblasts will lay down fibrous tissue that will become, the organized fibrous tissue that will take care, of replacing the area of injury. Now, that fibrous tissue itself may actually attract calcification to it. Okay, any kind of injury in the body, any kind of changes to normal in the body may actually call in calcification. And that may happen in one of two ways. Either you have a normal, calcium level or you have hypercalcemia. So calcification may happen in one of two ways, either a normal calcium level or actually hypercalcemia. The normal calcium level, that is going to go to the site of injury is what you call dystrophic calcification. Now, if it's in the breast, that actually may open a Pandora box for the treating physician. Why? Because those calcifications are going to appear on someone who's doing a mammography for a follow-up of cancer, right? Or for trying to to see if there's any tumor developing in the breast in the form of surveillance of breast cancer. So when those happen, and usually that's going to happen many years down the road, after the person have forgotten actually that they have gone through a traumatic experience on the chest wall, for example. So this is why it's going to become hard to actually to create the link or to make the link between calcification and the trauma that happened in the first place. Okay, the fact, the more remote it becomes, the more, longer time period that will pass by, the patient will forget. And as a result of that, the patient may be in for a lot of what you call investigation that will turn eventually out to be all negative if it happens in the breast. Okay? Does that ring a bell? Go ahead.
Dystrophic calcification happens to normal people or like?
No, in damaged tissue, wherever that is. Let's say damaged valve, for example. Damaged valve in the heart that may actually call in, deposits of calcium. That's what you call dystrophic calcium. Let's say someone actually got a, pneumonia, for example, and then healed by a scar. The scar that resulted, from the, infectious process may actually also, call in calcification in several years down the road. So, it happens actually in people who have a normal calcium level. Now, the other calcification that may happens actually when people, have hypercalcemia. Hypercalcemia. When does someone have hypercalcemia? Do you guys know? What is it? Low PTH? High PTH, right? Now, so high PTH. Is this the only time you guys? So what's high PTH? What do you call that condition?
Hyperparathyroidism.
What kind of hyperparathyroidism? Primary, right? Primary. Could secondary hyperparathyroidism? Is there a secondary hyperparathyroidism? Yes, there is. How does it happen?
Hypertension.
Cause of hypocalcemia, right? And why does hypocalcemia happen? Mainly really due to what? To thyroid? The thyroid, the what? The kidney, excellent. The kidney brown. Why the kidney would be? What? 125 dehydroxy vitamin D, right? The active form of the vitamin D. And if vitamin D is missing, what will happen? Then you will see that not osteoporosis. That when vitamin D is missing, what's going to happen is that the absorption of calcium from the GI is going to go down, right? So that's one way actually for that to happen. And then as a result of that, the PTH will be called in, right?
Yes.
PTH will be called in from, from which cells?
Chief cells.
In where?
Thyroid.
You call it chief cells, you call it C cells, right?
Yeah.
In my days, they used to be calling it C cells. Okay. Now, any tumor could arise actually from these C cells?
Yes. Yeah.
What kind of tumor? How about this? You will ask yourself, now you don't need to go home, right? You all have your great, computers, handheld computers, your cell phones, okay? what kind of tumor arises from the cells that secrete calcitonin in the thyroid?
How do you know?
Medullary carcinoma. Medullary carcinoma. A special form of tumors, medullary. Huh? No, pheochromocytoma is the adrenal, right? So medullary carcinoma. Could you connect medullary carcinoma with pheochromocytoma?
Yeah, both of them are neuroendocrine.
Right, very good. But is there like any syndrome where you see actually the two may happen?
It has something to do with sympathetic ganglia.
Huh? HL1. VHL1, von Hippel-Lindau syndrome. No, unfortunately. As much as I wanted to say yes to you, but it's not the case. How about MEN, multi-endocrine neoplasia? There's MEN1, MEN2, right, and most recently MEN3. So you may actually as well, read about it, and you will see, where you would see medullary carcinomas and pheochromocytomas. I believe it's into Patagonia. I'm very bad in numbers. This is why I cannot save any money.
Doctor?
Tell me.
The calcification scar tissue only happens in fat necrosis, right?
Scar tissue happens anywhere you have injury.
Calcification of scar tissue.
No, calcification happens anywhere. Wherever there is a scar, there is a scar, that may actually call in calcification. In normal calcium level, which is the process that you see in dystrophic calcification. Okay? But I'm just, I'm extending it to, hypercalcemia, because when you talk about calcium deposit, you have to talk about, when it happens, other than, normal calcium level. So, hyperparathyroidism you guys got. Is there another reason? There are two most common reasons for hypercalcemia. One of them, thank God you knew from your endocrine and repro block. So it's paying dividends. Congratulations. This is one. Then the second actually cause for hypercalcemia is where? Hypercalcemia. Excellent. Not metastasis, but cancer. Cancer in general. Malignancy is the second most common cause of hypercalcemia overall. Okay, that shows you how common it is. This is one. And two, it is the most common in hospital setting. So now you can differentiate between hypercalcemia and in community setting, which is a primary hyperparathyroidism, and in hospital setting, which is malignancy. Okay? So keep that in mind when you see someone who's coming in with increased calcium. All right, so now what's fibrinoid necrosis? When you talk fibrinoid necrosis, you're talking actually about immunologic injury, okay? Where you see that actually there is, we know the basis for, autoimmune aberrant autoimmune response, right? There are many ways for that to happen. One of the most common and accepted actually theories is molecular mimicry, right? When there is a immune response against an antigen that looks like something that the body should mount an immune response against, and it ends up actually that the antigen is actually a self-antigen. So that's what you call autoimmune response, because the immune response in this case is mounted against a self-antigen. Now, there are many different types. For example, one of them is going to be in situ, where the injury will happen in the tissue itself. The second one is going to be what you call antibody antigen complexes, or antigen antibody complexes that will be circulating with the blood. Okay? Everywhere where they get deposited, they are going to actually result in injury, because they may actually fix the complement, and the end result of that is going to be necrosis of the tissue where they are going to be getting deposited. Where do they get deposited? That actually may be in many places. For example, within vessel wall. Within vessel wall, so what will happen to the vessel wall when that actually immune complexes get deposited in it? It will be breached, right? And it will become very permeable, right? So part of it is going to, you'll start to see that the blood is going to start to leak to the vicinity of the vessel, resulting in an immune response to the to the leaked blood in that region right here, okay, and also to the immune response that is happening within the vessel wall. So a couple of things that may result actually in mounting an immune response to this poor vessel that is attacked by the deposited immune complexes. One of them is the fact that you have an immune response happening within the vessel wall. The second thing is the fact that plasma proteins will start to leak out of the vessel, lumen into the vicinity of this vessel wall, creating an immune response on its own. The end result is going to be this kind of presentation where you see that the vessel may actually become obliterated. It may result in complete blockade of the flow of blood because of the obliteration of the vessel lumen with the immune response. Now, let's go back a little bit. But that's not really the only place where that happened. Let's talk about, for example, something like rheumatic fever. Better yet, I like rheumatoid arthritis. Rheumatoid arthritis, not here. Okay, rheumatoid arthritis right here. So that's what you call actually the pannus. The pannus is really like, if you think about it, what happened, you have again, like, why does it happen in patients who have rheumatoid arthritis? Because of, for example, one of the explanations, molecular mimicry, where you see an immune response going actually after they call it an immunogen, or erythrotrogen. So this is what's going to result eventually in the destruction of the joint space. And that's going to happen actually where you will see immune response coming against this erythrotrogen, resulting in the formation of an immune complex that will start to get deposited in the synovial membrane of the joints, and everywhere it gets deposited in the body. So this is why you see that those patients with rheumatoid arthritis will not only have features that are consistent with arthritis, but they may have also pneumonitis, they may have tendinitis, they may have carditis. They will have inflammation any and everywhere those immune complexes are going to get deposited in. Okay? So, and then it will be actually, what's going to happen, why does it happen in this poor joint space is going to be affected with this inflamed synovium. It will start to proliferate, okay? So it will get bigger, start to proliferate. It will compress, that very tight space as a result of several mechanisms. One of them, and the main really one, is going to be the obstruction of the supplies of the articular cartilage from from the nutrients that are present in the synovial fluid. The end result will be destruction of the articular cartilage, and then it's going to result in actually fibrosis of this inflamed tissue that's going to turn the joint space into what? Into one piece. The joint is made up of two pieces, right? Two long bones that are sitting side by side. As a result of the fact that now you have a third part that is present in the joint space itself, it's going to be inflamed, it's going to heal by fibrosis, and then to answer the question, it will calcify. Exactly. That will result in what? Ankylosis or fusion, which is what you see with rheumatoid arthritis. So really, like, calcification can happen anywhere. Also dystrophic calcification. Exactly, ankylosing spondylitis, that's going to also it's autoimmune mediated kind of arthritis, where you will see that, but in that disease, you will see that the action is focusing on mainly, the vertebral column with or without peripheral, joint involvement. So those actually are going to result in what's known bamboo, I'm not sure. I'm not like, I don't have any fancy furniture, so I cannot know. Is it bamboo or bamboo? Bamboo, right? Bamboo spine, because it will become one piece as a result of the fusion of all actually those joints that connect the vertebral bodies together. Okay, posteriorly and anteriorly.
You used a specific word for when the joints fuse. What is it?
Ankylosis. Ankylosis. This is where ankylosing spondylitis come from. Okay. All right. So it can happen anywhere. So vasculitis. So how would a patient with autoimmune disease present? How do they present, like, for example, rheumatoid arthritis, sure, they are going to present actually with disease in one joint, right? But in general, do you look at one joint or should you look at everywhere? Exactly, systematic. That makes it really a very hard diagnosis. Now, why is it systematic presentation? Almost all autoimmune disease are systematic presentation. Why?
Because the immune
One word. Which means what also? Trying to drag it out of your mouth. Because there are vessels everywhere, right? So the presentation will be everywhere as well. Everywhere it gets deposited, it will result in presentation. Wherever it happens, right? Right, so what's rheumatic heart disease that's going to follow rheumatic fever? How does that happen? Is it infectious, right?
Yeah.
No, bacteria.
I'm gonna shoot you myself.
No.
It's not an infectious process. What is it actually?
Autoimmune.
It's autoimmune, exactly. Following infection.
Yeah.
It's following the infection, right? With the streptococcal infection.
Septic.
That's going to be actually coming much later after that. That's going to be focusing on the rheumatic, the cardiac valves, right? The cardiac, valvular leaflets, right? That is going to result in, what will it result in? Let's say that this actually, valvular leaflets first got inflamed. What will be the problem with those leaflets first? Will they close well?
No.
So that's going to result in what? Regurgitation. But then eventually they are going to be inflamed, and then they are going to be fibrous, which will result in what? Stenosis eventually, right? So regurgitation, then stenosis during the course of that disease. Right, so Michael Bob, I already told you that. I cannot ask you about this. Okay, we did talk about this. What else? All right, gangrenous necrosis. So gangrene, you guys know about gangrene, right? Are you fans of horror movies?
No.
You see a lot of gangrenes in horror movies, right? A lot of blood spilled everywhere. This is the favorite of my 7-year-old son. He loves horror movies. What does he get out of it? I have no idea, but he simply adores horror movies. And he gets scared. Not that he does not get scared. How would you like someone that you get scared of? I cannot understand that. And it has to be a real horror movie. You cannot give him like something lukewarm. It has to be something like very, very heavy-hearted. All right, so how does that happen? Let's see gangrene. There are two types of gangrene. Again, read it from this version, okay? Why? Because a slide changes, but actually it does make sense. Here, the dry gangrene, I want you to think about it as an infarction that has been happening very slowly, okay? Very slowly. Why? Because at the end of the day, infection did not happen, meaning that there has been a lot of collateral circulation that has been built over time that has supplied actually blood to the affected area, which means that the defense mechanisms are not really completely gone. Okay, so the end result is going to be what? The end result is going to be what? Sure, there is an infarcted area, and we have talked. Actually, we started this by talking about infarction equal to coagulative necrosis, right? So the way to think about dry gangrene is actually a coagulative necrosis happening at the level of a limb, okay? Or at the level of a full-size tissue, if you will, as opposed to part of the myocardium or small part of any tissue. So here it is much more bigger than that, usually affecting the fingers, toes, the tips of the nose. Where do you see it? Usually you see it in patients with atherosclerosis and diabetes.
Yeah.
Diabetic patients.
And let's see, what can I ask you about this? Not much really. All right, so remember that happening slowly to an area, and the reason for that is that there has been a lot of collateral circulation that came in, that kicked in, that were able actually to maintain a little bit of flow to that distant region, to allow that distant region to mount or to have some kind of defense mechanisms against infections. Now, on the other hand, if you actually go and look at the wet gangrene, you will see that the ischemia that happened in those patients usually is abrupt. So it simply, did not allow for any kind of defense to happen in that region. This is one. So as a result of that, you will see that infection will set in pretty soon, and as a result of that, you will see the appearance of the wet gangrene. So the wetness will come from the fact that you have actually an infectious process going on at the same time with the ischemic process happening that resulted, in the infectious process to start with. So again, if you want to think about, what a dry gangrene would look like, it looks like a mummified appearance. We used to get a lot of those actually feet, A above the knee, A above the knee amputation, and BKA below the knee amputation for patients with diabetes, mostly with diabetes, pretty much the whole. I rarely actually saw any patients who are coming in with, with only atherosclerosis. Usually it's either diabetes or a combination of atherosclerosis and diabetes. And what you're going to be seeing is really, when I had, one of those two girls, it used to be a tragedy day, really, because it's usually huge. You have to carry it like a baby in your hand, and you have to actually go through, the vessels one by one, the tibial vessels, and to see, and before if it has any part of the femoral vessels as well, to make sure that you are documenting the areas that are affected with the with the stenosis, documenting where the stenosis happened in those patients. Yes, ma'am.
Why is it only common in the leg and not the arm and hands?
I always ask this question to myself, and I cannot find the answer to that.
More prone to injuries.
Not really. Prone to injury would happen after you start to see the sensory neural kind of deficiency that you see with patients with diabetes when they start losing the proprioception.
Neuropathy.
The what? I'm sorry.
Neuropathy.
No, the neural.
Neuropathy.
Neuropathy, right? So, peripheral neuropathy, right? They will lose the proprioception, the sense of proprioception, which is the sense of the position of the foot, actually. How they are laying their foot on the ground, and as a result of that, they may actually be exposed to repeated trauma that they will never feel anything about, which is going to open the door for actually, right? But what happened probably, I would think that probably, unless you are an athlete, for example, that you're not using your lower limbs as much as your upper limbs. Your upper limbs are in direct motion because you use it in everyday kind of activity. Whereas the lower limbs, especially those that are far away, you're talking about the most. This is from the hand, I believe. So in this case, you're getting, is it the hand?
No, it's a foot.
This is good. This is, you're right. But that one is taken out completely. No, this is the, I believe this is not diabetes, this is actually frostbite. Whereas this one is diabetes right here. Yeah, so anything that is going to obstruct, but why actually lower and not upper? Probably it is because of the movement rate. I would think that probably this is it. What causes actually the injury in diabetes? Do you guys know? You just have taken endorectal, right? So it's a fair question to ask you that. What are the causes of injury? So actually, why do you have diabetic foot to start with? Why do they have this kind of presentation to start with? Huh? Poor healing, right. Well, that is part of the whole, but why do they have this poor healing?
The nerves.
The what, I'm sorry?
Nerves.
So the problem is with the nerves.
Glucose level is high in the blood.
Blood supply. Is it so the blood supply from the heart? No, not the heart. It's blood supply, but is it the blood supply or is it? It's not the vessels. It's not the nerves. I just gave it to the vessels. It's the vessels. I could not hide the answer. So the vessels are affected. The problem is with the vessels, really. Okay. So what causes the injury in the vessels? Say it again. glycated, I would say. It's not really. Glycated probably is British. You don't want to go there, right? So glycated end products, GP, of glucose metabolism, okay? So this is actually what's going to be roaming the blood in the patient with diabetes. So as a result of that, what does diabetes actually look like in a way? What goes also with the blood everywhere in the body that may result in, distant metastasis? Cancer. Diabetes is really, if you think about it, is probably worse than cancer. Because with diabetes, the injury is it's far more likely to happen than with cancer. Because cancer cells, not all cancer cells will metastasize. There's only a very, sturdy, very violent, number of few cancer cells that are able to make it actually away from the original tumor. Whereas with diabetes, these actually GEP are circulating the blood of the poor diabetic patient day in and day out. So what's the best way to make sure that this does not happen?
Control.
Control of what?
Blood sugar.
So it is really the control of the blood sugar as much as possible to normal. Is that possible?
Yes.
Yes.
No. Not if you live in the Gulf, that's for sure actually. Why is that? Because the diet actually is really, right? So can you live your life without sugar? This is the answer. Could you live your life without sugar? Anybody?
Yeah. They
No, you
can
cannot.
try.
Absolutely not. You cannot do it, unfortunately. Yeah, that's what it is. Okay, so sudden reduction, remember that. With blood gangrene, there's a sudden reduction. That actually is going to open the door for an infection to happen much easier than what you see with dry gangrene, right? Because here, the blood simply has ceased all of a sudden. What could cause actually sudden reduction? Not thrombosis. Thrombosis, that's going to take time, will result actually in a lot of collateral circulation that will be, right? That will be created over a long period of time.
Stenosis.
Well, you guys are lawyers, right? Again, the legal answer. You're right somewhere, Stenosis by what? Here's the antidote to you. Stenosis by an embolus, right? An embolus that is going to be going there and it's going to sit there and simply block the blood, completely, and once and for all. All right, so liquefactive necrosis, that's going to be again, remember coagulant necrosis when it comes to, the dry gangrene, right?
Yeah.
It's because, and the one here, did you say no? That's still actually taking the shape, right? Even gross shape.
Yeah.
So the shape is still out, even though it is mangled. I agree with you, I could not figure out. I thought that this is actually mangled. Then the other one does not look like a small finger, right? It looks like a huge finger. So that must be, actually the foot, part of the foot, anterior part of the foot. All right, so now, whereas here, actually you see that, the infection is going to set up. And then the infection is going to result in, what kind of infection may happen with gangrene?
Bacterial.
No kidding.
Sepsis.
What kind of bacteria? What kind of bacteria may happen?
Pseudomonas.
Pseudomonas.
Blood sugar.
Yeah, but there's better ones. How about if you're actually doing an examination of someone with wet gangrene, and you started to see actually some crackles under your finger. You started to see, first to feel bump, and then these bumps starts to crackle.
Yeah.
What is that?
Fermentation, anaerobic bacteria.
What kind of bacteria will do this?
Capsulated.
Gas-producing bacteria, like what?
Like
Clostridium?
Clostridium difficile.
Clostridium what?
Difficile.
Yes, say it. No.
Difficile.
Start with a P. Paraphragis. Very good. Paraphragis. That was my first autopsy, believe it or not. That was actually in 1999, and that is how long now? 20 years. Wow. I remember this. And he asked what this is. Clostridium paraphragis. Very good. All right. So now, gas production, and then also again, this is what I, wrote this question to you right here. So the whole thing, right? The whole works. In the US, they have a special type of pizza. They call it the works. Are you guys familiar with it? Where you find, all kinds of stuff in it. So this guy will have everything in it, right? They say it works because the whole milieu is there, really. It's wreaking havoc. So there are bacteria, there is ischemia, and there's there is an ongoing destruction of tissue, all happening, in this guy's poor leg. Where do you see it again? Whose patient is going to get it? Most likely it's going to be again diabetics and actually, patients who have atherosclerosis, who are going to be prone to developing actually, all kinds of, different cardiac, diseases, including embolism. One of the ways for that to happen in a distant region. Now, actually, I just, retrospectively, you mentioned something, or someone mentioned here, atherosclerosis, right? Not atherosclerosis, you mentioned something, thrombosis. So over the long period, right? But, you would say that, for example, if the patient is coming in with an atherosclerotic plaque that is plugging, his arteries in the leg, what's going to happen is that this is not going to be allowed to happen, all of a sudden, because the atherosclerotic plaque will take time actually to build up, right? But what may happen actually on top of the atherosclerotic plaque that may result in this clotting, which is what you call atheroma, right?
Yeah.
Now, why does a clot happen on top of the atherosclerotic plaque? I mentioned this to you before.
Viscosity of the blood, maybe.
Because of the disruption of laminar flow. Remember, two ways for laminar flow to be disrupted. One of them is when you have stenosis, which is what happened here, right? And two is going to be if you have the microcirculation. Thank you very much. It's nice to see that someone is remembering. Okay. Any question about necrosis in general?
Blood diseases can lead to this, for example.
For sure, absolutely. For anemia?
No.
Sickle cell anemia. Yeah, but sickle cell anemia usually. Gangrene in the intestine, right. That actually they have what's known as abdominal angina. Okay, and what happened in sickle cell, right? But I think like here when it comes to sickle cell disease, I personally never heard or never read anything about sickle cell causing actually gangrene in the lower extremity. Probably as a result of the caliber of the vessels.
I read in Dr. Oban's lecture last year that sickle cell anemia doesn't cause gangrene, but it
Does not cause gangrene.
Does. Because it gets stuck in the microcirculation, like you said, in the peripheral tissues, and then it causes necrosis of like the toe or like the knee or something.
Right, so it should be like a smaller kind of
Yeah,
growth,
it's not
as opposed to the larger caliber vessels. So it has to. Here or in fingers, toes, tip of the nose. Right, but what I'm saying again, it's not really that like you will not see anything like this. I believe, again, medicine you can never really you can never be so sure, right? This is one way for you to answer a question is never say never in medicine again, and that's probably it. Probably if you open like PubMed, you will see cases, absolutely. But again, I think it is the caliber of the vessel because you need a lot of these to have happen. But could it happen, for example, on top of an atherosclerotic plaque? Sure. Then it will be actually added more insult to the atherosclerotic plaque and plugged it with this, sickle cell plug, if you will. But there are other, conditions that may result in this. So there are other blood diseases that may result in this. For example, the P. vera, polycythemia rubra vera. Do you guys get that?
Yes.
Essential thrombocythemia.
Yeah.
There is also, so P. vera, essential thrombocythemia. I think these are the main two, where you will see that there are plugs of, but again, where do they do it mostly? They do it in the microcirculation. So you will see it, for example, in the liver. So blocking, the liver, outflow of the liver, the hepatic veins, resulting in liver necrosis, liver congestion, and then liver necrosis. All right, so caliber of the vessel is going to be. Any other questions, guys? Did you guys get a hang of it somewhere in your mind?
Yeah.
Okay. All right, let's continue with the apoptosis. That's a completely different process here. As I mentioned to you, chaotic nature to it, really. Now, if you want to take a cell in the body out, how do you take it out? Whether pathologically or actually, naturally, developmentally, I should say, not naturally, by apoptosis, right? And why is apoptosis going to be the answer for this kind of process?
Because we can't control it.
It's programmed for the gene level. It will be programmed to different some.
So for one, it is programmed, whereas the other one is chaotic in nature, right? This is one. Two,
Can be
would you
triggered.
want,
Can be triggered maybe.
not triggered, would you want inflammation to be set in? Do you want to set in inflammation? Absolutely not, right? That will be the wrong thing to call for. So, you don't want anything that is near inflammation in the closed space. And that's exactly why you would always, rely on apoptosis rather than, necrosis to take out any unwanted cell in the body. Now, that's a very controlled process that is going to actually result eventually in dismantling the cell one piece at a time in the form of what's known as apoptotic bodies. These apoptotic bodies are going to contain contents, like pieces, what you call a potpourri of what was in the cell at one point in time. So you will see cytoplasm, you will see mitochondria, you will see nucleus, and then that all is going to be surrounded by what? By a membrane, actually, right? And those membranes are going to be set out that are going to bud off of the cell in the form of apoptotic bodies. All right, the same here. Now, is the enzyme dependent? That's not really very unique to it, right? Because the other process is also enzyme dependent, correct? Both of them are enzyme dependent. The first one, the apoptosis is genetically controlled, and we'll see how does that come to happen. Now, in the process of actually this cell, breaking down into apoptotic bodies, nothing is leaking out of the vicinity. The membranes are staying intact. Like I told you, very Western way to die. Nobody will hear about you. Close your door and then you sit in your bed. And this is what they do in the West, right? Have you heard about those who die actually? And then they discover them about 3 or 4 months later, They usually are mummified in the best way, the best place to study, coagulative necrosis probably, if you ask me. All right, so in apoptosis, the cell will produce actually energy to die. How about that? How about, you spend, actually, if you think about it, life itself is like this, because you spend energy, and this energy is taking you one way, which is to die, right? Eventually. This is my black humor. I hope I'm not really setting off any alarm bells in your head. All right, so the contents are not released, and the extracellular space is free of any kind of inflammation. All right, so physiologic example. Now, this is really beautiful thing. Like, believe me, if I did not teach pathology, I would have loved to teach histology, and especially embryology, because I think it is one of the least well-taught courses in any schools around the world, not just in our school. So, here's a question. Give me an example of a tissue other than the thymus. Thymus is here, right? The thymus, you're born with 100% cellularity. At about 50 years of age, how much of that cellularity is left?
50%.
Not about, maybe not 10%, not 20%. That would be really, a very generous guess. Is there any other tissue in the body where you see the same? Not in this sense, no. Huh? The brain. You're picking very, very touchy subjects, Brain. True, actually, the brain does lose part of it, but it's not really like that much. Otherwise, someone will cross over into demented territory, right? So, but not the what you're born with, that is 100%, and then at 100 age, you're really actually supposed to have a 0% cellularity. Seminifrous tubules.
Nephrons.
They decrease after 40 by about 1% per year.
Nephrons.
The GFR decreases by about 1% per year after 40 years of age, or after 45 years of age, which is not really. Bone marrow, excellent. Excellent. Bone marrow, so you're born with 100% cellularity. And then if you want to do calculation, if you're looking at the bone marrow biopsy, the way to do it is age minus, 100 minus the age, right? So if someone is 100 years old, really, of course it's not going to be the case, but it's almost like, it's very, very little. And that's exactly, how does that happen? It happens as a result of involution, as a result of the apoptosis process. It does not happen as a result, God forbid, of a inflammation or as a result of necrosis, because that will wipe out the whole thing, right? You don't want anything anywhere else. How about actually, let's say, those inflammatory cells, those T cells that are self-reactive, do you let them roam the blood? Absolutely not. You have to kill them out. How do you do that? You do this also in the process actually of apoptosis. Anything else? Let's see if there's anything else. Now, what are the pathologic examples of apoptosis? Anything that becomes apparent within the cell that is outside the norm. So let's say that the genomic, which is the most important probably, that the genome of the cell have suffered a what you call irreversible insult. Is that gonna actually kickstart the apoptosis process? The answer to that is a resounding yes, absolutely. Why is that the case? Why would you worry so much about genome intactness?
Mutations.
Sorry?
It will pass to adultery cells.
Right. What will pass to adultery?
Mutations.
Mutation. Are all mutations, translatable mutations? Okay. What are the odds? How about 1 in a million? Actually, 1 in a billion. How about this? It is so rare that the mutation will be a translatable, a meaningful mutation. So that shows you actually, here's one thing. This is called deductive thinking. So that shows you that cancer is a very rare actually process, correct? If it's let's say only a million, right? Then cancer is a very rare process. What other deductions you take from this? If you look at the amount of cancer that we are seeing nowadays.
That maybe has an environmental factor.
Right. But my question to you is, how many mutations are happening? That means there are tons of mutations. As a result of those environmental factors that you're talking about that are everywhere causing these mutations, right? But that's actually a testament to the fact that you have not only, so it's a 1 in a million, but you're having a million type of mutations on an ongoing basis that one of them eventually will end up actually causing cancer, right? As a result of that, cancer became actually the most common cause of death, I think in 2010 or 2011, again to be superseded again by cardiovascular disease, most recently. Would you, how about this, I hate to be telling you, would someone rather die as a result of a cardiovascular disease or as a result of cancer?
Cardiovascular.
Cardiovascular.
That's exactly my feeling. Go ahead.
Okay, so you said that
If you have
an insult to
the genome, right?
So you said that it would become.
So why are you worried so much about this? One of them is because you're worried that there will be a mutation that will be passed on to other cells, right? Now the other thing is when you have, what did you want to say? What did you want to say?
I was wondering because you said that it becomes more like protein pops out. In the case of cancer, you upregulate your proteins.
There are different ways for cancer to happen. There are cancers where actually, cell, you're absolutely right, may refuse to die, or the anti-apoptotic, mechanism is so upregulated. But then there are cells, there are cancer cells where they actually are going to divide so fast, which is what you call rapidly dividing tumor. The anti-apoptotic tumors will be the slow dividing tumor, will be actually the very slow type of tumor. Clinically, like what they call it, clinically mild tumors. Okay? So different ways, of cancer really to happen. So, you would worry about the genomic insult because one of them is mutation, absolutely right. 2, you're worried actually that the cell itself will no longer be functioning, right? Because it will come to this point and it will not divide anymore, correct? So there is no continuity. Progenies are going to be less. So there will be a feedback mechanism that is going to make the cell, grow more, and that may open the door for a lot of abnormalities. So, you did mention actually the mutation, right? So now the other things actually that may result in apoptosis, including the accumulation of misfolded proteins, that is going to accumulate within the cytoplasm of the cell. Could you think about an abnormally folded protein or a misfolded protein?
Prion.
Prion.
I was like-
Wow, you guys are good. Where did you learn that?
More.
In what?
Biochemistry.
Biochemistry. Okay. So what are the prions? Misfolded. What makes them misfolded in the first place? Infection by what?
The beta chain.
By other abnormal proteins.
Yeah.
They call it recruitment of normal proteins, right? Do you really believe this? This stuff? Personally, I don't believe it. It's simply they don't know the answer to that yet, right? So because now they are saying actually that the protein itself is the hallmark of the disease. That there is really nothing, there is no nucleus behind it. How about this? Okay?
Alteration of the beta chain.
Alteration of?
Beta chains.
Well, of the protein structure, right? And what I'm saying, it is an abnormally structured protein. Absolutely, that is going to accumulate so much that it's going to create holes. Creating holes where, especially in the CNS, right?
Yeah.
In the nervous system, that's going to result in transduction signal, cutting, or non-transmission of signaling, of the neural cells. That may result in so many different neurological presentations. But what I'm telling you, where is the infectious agent? When you look for the infectious agent in those BSE, spongiform, bovine spongiform encephalopathy, you will not really see anybody talking to you about an infectious agent. They will talk to you about infectious protein. And they will tell you that the abnormal protein will recruit other abnormal proteins, if you can believe that. Now, the answer to that is simply they don't know yet. Probably they will discover it. Hopefully, you guys will discover it, and at one point in time, you will be winning the Nobel Prize in medicine. Okay? So that's an example. You guys went to the hardest one. Wow. Is there any other misfolded protein that accumulates in the cell? Amyloid, absolutely, excellent. This is much more common, right? Far more common than this. Where do you see amyloid? Alzheimer, okay, very good. Is there anywhere else where you see amyloid deposition?
Cystic fibrosis. And I think that's correct.
Okay, well, I'll give you cystic fibrosis. What else? Any chronic disease. There are different sets of amyloid. There is a primary amyloidosis, and then there is secondary amyloidosis. And in each one of them, there is a special form of amyloid protein that may result in getting deposited in cells, and then these cells are going to be kaput. They are going to die by the process of apoptosis. How about a cell injury, a cell infection such as HIV infected cell? How about actually an HBV infected cell or an HCV infected cell? In the liver, HCV, hepatitis C, and hepatitis B. What will take care of those cells? Virally infected cells.
Immune system.
HIV, I will keep it, probably if I have to do that, I will change, that here and make it HBV, because HIV, you will see several mechanisms working at the same time. Whereas with HBV and HCV, it's really much more straightforward. Which cell takes care of that virally infected cell? Not the macrophages. Natural killer or?
Lymphocyte.
Which lymphocyte?
CD8.
CD8. The CD8, the cytotoxic cell, right? The cytotoxic cell. Now, pathological atrophy and compression, for example. Can you give me an example of that? You mentioned an example a minute ago, which is?
The kidney.
Cystic fibrosis. Where is that?
Lungs.
But where does the pathological atrophy happen in cystic fibrosis? No?
CFP.
No? Lung has a lot of space. Pancreas. Very good. So pancreas. Now, okay, so what happened in the lung that may actually result in the same, lack of space to inflate? Diaphragmatic hernia, especially congenital hernia, right? Where you see that the contents of the abdomen are now in the chest. The lungs will not be aerated because there is no space for them. They may actually end up in atrophy, in pulmonary atrophy. All right, so what happened here is that actually, like everywhere in the body, you see actually two sets of genes, two families of genes that are under one family. So this is how it goes. It's like a story, right? This is what, the first time I presented an autopsy, my attending sent me, 4 times to my desk again because he told me I did not like the presentation. It was not in the form of a story. So I learned actually to present like a story. So you have to blame him if you don't like the story here. So what's going to happen actually is that there is one family of gene known as the BCL2 family of gene. The BCL2 family of gene have sensors known as the BH3 proteins, okay? Nuclear sensors that are going to sense when there is any kind of injury to the cell. When there is genomic injury, when there is mitochondrial injury, when there is cytoplasmic injury or membranous injury. And they are going actually to relay to the BCL2, but think about it as the crime boss, telling them, for example, that the cell has suffered an irrevocable kind of injury, irreversible kind of injury, okay? So in that case, you will see that that family of gene, the BCL2, have two arms. One of them is what you call pro-apoptotic arm, and the second one is anti-apoptotic arm. So let's say that the family of, let's say that the cell has suffered ischemia. So there are no more nutrients, there are no more oxygen that's coming to the cell, which, in your humble opinion, is going to be activated in this case.
Pro.
The pro-apoptotic family of cells. And how will they do it? So pro-apoptotic family of cells. So cells deprived of growth factor, they are going to activate the backs and the back. Those are the pro-apoptotic genes that will be translated into proteins. Then they will dimerize. What do you call dimerize? Is there an Arabic word for it? Dimerize.
Yeah.
Dimerization. To me, they get larger in size in a way, or they take shape in a way. And they are going to catapult themselves. They are going to insert themselves into the mitochondrial membrane, right? Allowing for the release of the contents of the mitochondria into the cytosol, right? And with it, the cytochrome C will be released. That will be activating the apoptotic process. Not only that, but also it's going to suppress the family, the BCL2 family of gene will suppress the BCL2 and the BCLXL that are the anti-apoptotic, genes.
Doctor, isn't BCL2 pro?
BCL2,
Have two.
BCL2 anti-apoptotic. So this is why if you have like a form of lymphoma known as follicular lymphoma, who asked about the cancer, the anti-apoptotic mechanism for cancer growth. Follicular lymphoma is an example of that. If you stain a section of follicular lymphoma, you will see that the BCL2 is loaded actually in those cells because those cells oppose apoptosis. But this kind of growth is going to be what you call a slow growth. Why? Because those tumors are actually forming as a result of the non-death of cell as opposed to the rapidly dividing cells. So this is why they present with smaller kind of tumors. And usually it is everywhere in the body, so it becomes really hard to treat. And affects people who are really older in age, like about 50 or 60, right? So as a result of that, what do you give those patients who have, anti-apoptotic mechanism of their cancer?
Suppress.
Nothing. You don't have anything to go after them, actually. Okay, at least, you may go after them, with the new medication that are on the market now, but it will not really be as successful as if the person has a rapidly dividing tumor. Okay, so BCL2, for the ones who asked, is actually the anti-apoptotic member of the gene. So the BCL2 is one big family, right? The mother family, if you will, and it has two arms. One that is anti-apoptotic, the BCL2 and the BCLXL, that are going to be actually upregulated when everything is happy and dandy. So the cell is fine, receiving enough amounts of blood, and receiving enough amounts of nutrients and supplies, no problem at all. BCL2 and BCLXL will be predominant. When that changes, then those are going to be suppressed. Back and backs will be upregulated, dimerized, or translated and dimerized, pushed into the mitochondrial membrane, and apoptosis will set in. I think that's pretty straightforward. Do you agree with that? Okay. So that's what it is. It's simply, right. So now, actually, here's a nice, sentence that comes to you courtesy of Papa Robbins. That when it comes to the intrinsic mitochondrial pathway, which is one of two pathways the cell could actually up to into apoptosis. One of them is the intrinsic from within the cell, In this case, the choice between cell survival and cell death is going to be determined by the permeability of the mitochondrial membrane. So that's actually the way it's really giving it to you in a nutshell. Okay? And those actually BAX and BAC and BCL2 and BCLXL, they are part of many more number of proteins, up to 20 proteins that are going to be there. But the 4 that you know about are really the most important and the most dominant forms of the protein, but there are more than just 4. It's always more complex than what you are reading here. Of course, you can go and read about it if you like. All right, so we did talk about all of this. The end result is going to be the release of cytochrome C that will activate the caspase 9, and then once that happens, the balance in this case is going to be tilting towards apoptosis, and the cell will soon be no more. All right, so now there is the death receptor pathway that is coming from the outside, the extrinsic pathway. Now the cell itself will carry actually a death signal, if you will. That tells you that every cell has its fate, right? Has its time. Every dog has its time. Have you ever heard this? This is from American movies, my favorite type of movies. Okay, so you will see, the death domain, also known as the death domain. What is the death domain? That's actually the TNF receptor family that are present on the outside cell. So the surface of the cell will carry this death domain that is going to be recognized by T cells. That's going to recognize this death domain, will recognize these fast expressing targets, and when the link happens between the ligand and the molecules that is circulating in the blood in the T cells, that's going to link. When they link up, then there's a number of adductor protein that will be released from the inner surface of the cell that will be activating the caspase A. But in doing so, it would have actually bypassed certain. Let me show you. Oh, the picture is worth a lot here. All right, this is what is meant by the fast ligand, the molecules that are going to be in the blood on the T cells. They are going to recognize these receptors on the cells that are showing them. And when the link happens between the receptor and the ligand and the molecule, adapter proteins will be released from the inner surface of these receptors that are going to initiate the caspases that are going to take the cell down the road of apoptosis. Now, as you can see, it would have bypassed the mitochondria in this case. It does not need to go through the mitochondria because now it has initiated the activation of the caspases all the way to breaking down the cells. Now, when it comes to the withdrawal of growth factors and hormones, that has to go through the mitochondria and through the nucleus, because as I mentioned to you, that's going to result actually in the switching of the balance in the BCL2 family of gene towards apoptosis versus anti-apoptosis, resulting in increased permeability of the mitochondria that will go and initiate the process. Now, one thing actually I want to tell you about is when a cell that is infected by a virus, as I mentioned to you, the HPV, the HCV. In this case, the cytotoxic T lymphocyte will take care of that. And that cell is rich in granzyme B, which is a serine protease, and also in another protein known as perforin. So those are going to come inside. As you can see, the granzyme B itself is going to activate the executioner caspases, so it will bypass the whole thing right here, okay? And then that's going to take the cell down the road of apoptosis. Now, perforin itself is going from the name, perforation, is going actually to create pores in the mitochondria and also in the cell membrane, easing the apoptosis process. Another thing actually, how does perforin cause it when it's working at the level of the cell membrane? So it's going to cause increased permeability of the cell membrane.
Yeah.
Then what will happen? What
Osmotic
happens?
pressure.
Then that's going to result in necrosis, right? The word is calcium. Remember calcium, right? When it goes in, and then it will work actually on the
Lytic
mitochondria itself directly,
Yeah.
right? So that's something to keep in mind as well. Now look at this. How about actually if you have a cell that simply is becoming senescent, old? What's going to happen is that there is no DNA damage really, but the p53, which is the guardian of the genome, will sense that there is a small part of the genome of the cell known as the telomere that has become so shortened, it becomes like a small break of a double-stranded, DNA. And when that happens, the p53 will go and activate the executioner caspases on its own, taking the cell down the road of apoptosis. Okay? Another way actually for that to happen is when this p53, instead of knocking the cell down and breaking it apart in the form of apoptosis, it will actually put it in a phase, in a non-replicative phase known as senescence. Senescence, which is translated in Arabic into senescence. You guys don't speak Arabic, don't you? Thank God you all will be living outside because your patients here will not understand what you are saying. Shaykhuha.
Oh.
Yes. All right, so how about actually if the cell suffered DNA damage? As you can see, radiations, toxins, free radicals, right? The end result will be what? p53 will be activated again, will take care of the cell down the road. Do you guys get that? They say a picture is worth 1,000 words, right? You can write about yourself like pages. One picture will tell everybody all they need to know about you. So if you read this picture, you will be fine. So once that happens, once those executioner caspases are activated, they will start to tear the cell one piece at a time. Everything in the cell will go. The nucleus will go, the mitochondria, the ribosomes, everything. Now all of this is going to be actually coming close to the cytoplasm of the cell, the cytoplasmic membrane of the cell. And then it will start to bud off. And that budding is going to contain potpourri of what was inside the cell. So much so that at one point in time it will break from the cell membrane. And that structure right here is what you call the apoptotic body structure. Okay? So the cell will break down into apoptotic bodies. Now how will they be taken out? You will see that the cell itself on its inner surface, on the inner surface of the cell membrane itself, everywhere you go, is a special serine protease signal known as hold on a second. The eat me signal. How about that? Eat me signal. Ligands that are going to be recognized by phagocytes, by macrophages. So you can see that the macrophages will come, recognize those actually eat me signals, on the outer surface of the cell, of the apoptotic body, and they will take it in the form of a complete kind of crime. Nothing is actually left as evidence that the cell was there to start with. After a while, after the cell has been broken down, piece by piece. Okay? Clear? Okay. We come to it a little bit here to see if we missed anything. All right. So this is this receptor pathway. Now there's something coming from the outside. All right. Activation function of we did talk about this. All right. So I'm sorry, not the phosphatidylserine that is on the inner surface of the membrane. That is the eat me signal. Simply, recognized by the macrophages. Macrophages will come in and will take care of business. It will help those apoptotic bodies one piece at a time, simply leaving the cell, leaving a hole really where the cell was in the first place. The three phases of apoptosis, the initiation phases, that's actually activation of the initiation, caspases. That's going to be followed by initiation of the executioner caspases. That's going to be followed eventually by cell death. That's going to be mediated by enzymes, eventually removal of the dead cells through the process of phagocytosis, one piece at a time. So if I ask you a question on the exam, and I will be actually holding myself to that, if I ask you how does the cell die in apoptosis, and if I tell you, or how is the cell, parts taken up by apoptosis. If I tell you phagocytosis, that will be the right answer, right? Because that's exactly what happened. Phagocytes are going to be rolling the day, taking in those apoptotic bodies one piece at a time. How does a cell that is affected by apoptosis look like? So these cells actually are not going to suffer the changes that you see with reversible cell damage when the cell has an influx or having influx of water in, right? Those cells are actually going to start to scale down because they are losing one apoptotic body at a time. What will happen to them? They will start to become smaller. They will shrink in size. What happened to their nucleus? The nucleus will become also shrunken. And then the nucleus will start to fragment, right? If you recall, I told you that pyknosis and karyolexis and karyolysis are really mostly what you see with apoptosis rather than with necrosis. Even though there are no book, but listen to me. One day I'm gonna call it, I'm gonna be publishing it, that actually it is more, and it is wrong really to go with necrosis for the three changes that we have talked about rather than with apoptosis. Robbins does not really make that distinction on where to find these nuclear changes, but in reality you will find it, in my humble opinion, only with apoptosis and the pyknosis, the karyolexis, and the karyolysis. All right, so eventually they are going to break down. You're taking pieces of the cell will get smaller in size, no question about it. The nucleus will get smaller in size because again, it's becoming it's scaling down, getting smaller and smaller. Eventually it will simply disappear with no inflammatory response nearby whatsoever. All right, here's an example of this. This cell will actually be coming down so much at one point in time, it will simply disappear. When the cells disappear and the pathologist is reading a slide, when they refer to an apoptotic cell, in what you call it, pathology, colloquial talk, they call it a drop out of the cell, because simply the cell is no longer there, okay? And there are a lot of conditions where you may see actually drop out or apoptosis that probably you guys are not responsible for now, but you may actually think of, for example, graft versus host disease. The GVHD, that's actually one of the scenarios where you have apoptosis, especially in the GI system. Example of that is what you see right here, okay? So they look for the GVHD, which is going to follow, someone who received a bone marrow transplant, and the GI to look for evidence of, this disease in those patients. And that's an example of that, where you see that the cell itself becomes, much smaller in the form of apoptotic cells. At one point in time, as you can see, it is really on its way out, completely disappearing. Here is an example of a cell, hepatocyte, that is affected by a viral infection, by hepatitis B or hepatitis C. It's going to result in turning the cell into an apoptotic body, a big piece, of apoptotic tissue known as the consummate body. So what's the consummate body? The consummate body is an apoptotic hepatocyte that is affected by a viral infection, okay? Affected by one of the chronic hepatitis infection. What do you see with so this is with regard to hepatitis B and C. What do you see with hepatitis A? Example. As an example of
Necrosis.
acute inflammation. Exactly. You see necrosis, which is one of the only thing that you would worry about in patients with hepatitis A is liver necrosis, especially what you call fulminant hepatitis that may take them. So in that way, what do you think those cells are going to be mostly dealing with in this case, hepatitis A? It's going to be mostly of a necrosis kind of presentation, as opposed to what you see with the chronic hepatitis, which is going to be mostly with apoptosis of process, okay? All right, so apoptosis versus necrosis. Look at this. What could you tell me about, the apoptosis right here? So first, the cell becomes smaller. So what you call condensation of the cells, right? Smaller cells. And then they will start to break apart, right? Creating the apoptotic bodies and then simply disappearing. What happens on the other side to the necrotic cell? The first stage is going to be, the reversible cell damage, right? That's when the water is coming in. What will happen to the cell? It will increase the size, right? And then the cell is going to actually resort to the glycolytic pathway to get its, its ATP. What happens to the glycogen stores in those cells? They are going to be depleted, right? The cell will become smaller. So the cell will grow first and then it will become smaller. But what's going to happen as a result of the fact that you will have, for example, the influx of calcium, or actually the reach that will happen in the lysosomal vesicles, right? Or in the mitochondria itself. The end result is going to be what? The end result is going to be activation of those enzymes and digestion of that cell that will result in releasing contents of these cells to the vicinity of the cell, resulting in an immune response and simply inviting the rest of the immune cells to come down and take the cell out wholesale, right? In the form of necrosis. So first the cell will die, at least in the early stages, by its own enzymes, and then the immune cells will come in and will complete the job, right? Destroy wholesale. So again, you can take that with so enlarge first and then decrease later, if you agree with that. So that's not really to ask you about, because pycnosis, as I mentioned to you, I disagree. This is from Robbins. I disagree with that very strongly because I believe that this should be here really, okay? But, we'll see about this. And then, enzymatic digestion, where the cell contents will be leaking out. Here, the cell will stay intact and the formation of apoptotic body will set in. And then no inflammation with apoptosis, frequent inflammation with necrosis. And finally, when it comes to necrosis, always pathological, whereas with apoptosis, it is physiologic, maybe pathologic as well. Okay? Well done.
Thank you.